So thank you very much for giving me the opportunity to give this presentation about the adverse events with immune checkpoint inhibitors. First of all, to introduce myself, I'm a medical oncologist. I work at Gustave Roussy in the Department of Drug Development, and I have been able to see many patients treated with PD-1, PD-L1 inhibitors, and that's the subject of my talks today. It's a bit sad that we didn't get the presentation about melanoma, because I think if you haven't seen results that these drugs obtain in melanoma, I think the main thing you should remember about this is that in melanoma it can induce prolonged response and control of disease for a long time. It sometimes gives complete response, but also stable disease for a long time. And I think the whole enthusiasm with these new drugs that modulate the immune system is there. And people are hoping to see such results in other solid tumors. So many different molecules are developed right now. CTLA-4, as we mentioned, for lung cancer has been mostly tested in melanoma. And there have been several drugs that have been FDA approved for melanoma. Ipilimumab, which is the first generation of the anti-CTLA-4, and also pembrolizumab is named Keytruda in the US now, that has been FDA approved in September 2014. Nivolumab has also been approved in Japan most recently. And as you can see, there are multiple drugs that are targeting this new pathway of immune checkpoints. And I'm not mentioning here, but most of the pharmaceutical companies are actually developing their own immune checkpoint inhibitors right now, because they realize that's key for the future of cancer treatment. It was first developed in melanoma, as we mentioned in the previous talk, but now it's tested in various different diseases, lung cancer, as we mentioned in the previous talk, but also very different type of tumors. And actually, I would say all tumors are going to be tested right now with these new treatments. So what is for sure, we will hear about this more and more if it's working, but we have good signs of proof of the concept. And so I think it's important that you are aware of the toxicity, because it's a new way of toxicity that we'll see with this medication. You will see EKIs is actually immune checkpoint inhibitors in my presentation. The way it works, as we have seen, is it reactivates the immune system against the tumors. So we have tumors, lymphocytes within our immune system that are effective against the tumor, and thanks to these immune checkpoint inhibitors, we reactivate this immune system. This is responsible for activation and also cytokine release, and this leads to novel spectrum of adverse events that are immune-related, called immune-related adverse events. This is a typical schedule of treatment. This drug is usually given, so I'm talking about PD-1, PD-L1, is usually given every 2 or 3 weeks, compared to anti-CTLA-4 like ipilimumab in melanoma. It's only 4 injections. And this is a typical course. So you start PD-1, PD-L1 inhibitors. You continue it based on the CT scan that shows you stable disease or response. At one point, you stop either because the patient progresses or because of toxicity. So we face different types of adverse events. We have early adverse events that are pretty rare. Most of the time, patients tolerate the medication really well. It's almost as if they feel like they're coming every 2 or 3 weeks for their saline IV infusion, like they feel as if we're just giving them saline. After a certain time, some patients, and it's not very frequent, as you will see, present delayed and sometimes off-treatment adverse events. So why is this reason of such delayed adverse events? You have to understand that these medications are not targeted therapies. Yes, we're targeting a ligand, PD-L1, but it's not like a receptor and a direct effect. We are targeting the immune system, so it has a more global effect. As I'm showing here, with this treatment, we activate these tumor-specific T cells that are in our body, that proliferate and that hopefully control with a polyclonal control of the tumor. And so as you can see, and as you know, with vaccine, for example, it takes time to get immune efficacious against your cancer in this case. If you think in terms of autoimmunity, what this treatment probably induces sometimes is it reactivates autoreactive clones. And so this clone will trigger an autoimmune disease or autoimmune symptoms, then can be delayed even later than the response of the treatment induced by the treatment. And this is the typical kinetics of appearance of immune-related adverse events with ipilimumab. So ipilimumab is the anti-CTLA-4. It's called Yervoy. It has been approved for advanced melanoma in 2005, I think. This shows you that the most frequent and the kinetic of this adverse event. You may have rash at the beginning with pruritus that actually decrease with time. And then the incidence and grade of diarrhea and the risk of colitis can appear later. And same for liver toxicity or hypophysitis that can actually appear later on after, and sometimes after the treatment, because as I told you, ipilimumab is only being given for 4 injections. Why do we have such toxicities? As I say, we may reactivate autoreactive T cells within our body, but we may wonder if there's other risk factors, and this is a hypothetical model we're proposing of, yes, the immune system is reactivated and can have a direct effect on and trigger toxicity, but you may also have tumor disease that can actually grow, and that's called pseudoprogression, when the tumor actually starts growing before responding after a certain time, where there's an infiltrate of lymphocytes. Also, we may wonder, and it's just hypothetical, if opportunistic pathogens may trigger, for example, pneumonitis. I'm saying this is just hypothetical. We have no proof of this, but this is part of the hypothesis we can come up with. And also the genetic background. Why would some patients develop colitis where other people don't? Well, why do some people develop Crohn's disease and some other don't? So maybe there are things to look at there, but so far it's very hypothetical. So as I say, these are new type of adverse events. They're immune-related, and so therefore they can involve any organ system. And this new kinetic, as I say, it can appear during treatment, but also weeks or months later after discontinuation. So that means we have to be careful about this, address these symptoms early, because the later you treat an autoimmune disease, the more difficult it's going to be. And also we have to educate patients about signs and symptoms associated with this autoimmune disease. This is the typical risk management wheel, and we can apply it for taking care of these autoimmune symptoms or disease. First of all, we have to try to anticipate by informing patients and physicians. What does it mean? That means that we have to tell our patient, well, if you present any new persistent or worsening symptoms during the treatment course or later on, you should contact us. Don't wait 2 weeks later or 3 weeks later, because getting the treatment right away may help to keep these problems from becoming more serious. So it's important that we as a physician, but also patients, are aware of this, and we have to have a team dedicated to get the patient on the phone and to tell them what to do in case of new or persistent or worsening symptoms. To prevent such autoimmune-related events, we need to get information about the risk factors of the patient. So that means getting information about autoimmune disease history in the patient history or in his family, or other conditions of the lung and the liver, or severe infection history. Also, we have to be informed about concomitant medication and potentially, and this is hypothetical, medication that are associated with autoimmune diseases. So once we say this, how to detect such immune-related adverse events? Technically, when you see patient, if they usually they tolerate well the treatment, you see them, and suddenly they start complaining about something. So any new persistent or worsening symptoms. So as I said, it can touch any type of organs. These are the most frequent ones that have been reported with CTLA-4. This is from the risk evaluation Yervoy label. So these are the most frequent ones: gastrointestinal with diarrhea and colitis, liver with abnormal liver test, skin with pruritus and rash, endocrine with the most frequent is hypothyroidism, and also neurologic. There have been some Guillain-Barré syndrome that has been reported. But technically, all organs can be touched by these autoimmune adverse events. And so either like pericarditis, like you mentioned for earlier, or eye with conjunctivitis. So, and also respiratory with pneumonitis. So many organs. So we have to be literally aware of what's happening with our patient and go and investigate what's happening. I'm just reporting here the different toxicity that have been reported with the free medication that have been approved on some markets. So ipilimumab in France, in the US, pembrolizumab is temporary use of utilization, and nivolumab in the US. As we mentioned earlier, ipilimumab, which is an anti-CTLA-4, has a higher toxicity rate, and the PD-1 inhibitors like pembrolizumab or nivo have a lower rate. But you can see that they do have some important percentage, for example, for hepatic, for gastrointestinal, and I'm talking here about all grade reported adverse events. There's something that is important when you read the publication is that they will give you the number for any drug-related toxicity, and usually they will mention a lower rate overall because they will tell you about drug-related and mostly immune-related. So sometimes they consider it's not immune-related, so they say it's not associated with the drug. And so in that way, sometimes you will see very low rate of toxicity. It is true. I mean, in the daily practice, we don't see that many toxicity, but you have to be aware that there can be many types of toxicities, and so we have to be very careful with those medications. So what type of adverse events we have to look for? Fatigue, cough, nausea, pruritus, rash. Diarrhea is one of the main ones we have to be careful of. Why do we have to focus on this? Because the most frequent one, like colitis, can be lethal with perforation. Pneumonitis with acute insufficiency. Neurological with Guillain-Barré. And hepatic or endocrine are also very important ones. So once we detect it, how do we act in front of these immune-related adverse events? Well, like any other patient, first you bring them to the clinic because you have to see them quickly and evaluate them physically and with lab tests. And you have different options then. Most of the time, and I think in terms of lung cancer, it's disease progression. And most of the time you will feel, okay, well, he's progressing. And sometimes it's immune-related adverse events, and also sometimes it's something completely fortuitous, like a viral infection. No matter what, you always have to think about immune-related adverse events, because respiratory insufficiency for pneumonitis in lung cancer, it can be progression, but if it's autoimmune, you don't treat it the same way, and so you always have to consider what if it is immune-related. So once you have identified a problem, you have to grade it, because as you will see in the next slide, there's guidelines to help you to manage these symptoms and to help you how to treat them. And so to grade means you're going to be a good friend with the CTCA4 that helps you to tell you if it's a severe or not severe toxicity. But technically, in the daily life, the question is more, how does it affect you in the daily life? Does it affect your sleep, your daily activities? And if yes, well, that's severe. Mostly, it's helping you to take the thing seriously. So how to treat immune-related adverse events? First of all, you will see there's many guidelines developed by the industry. Some of them are published. We'll talk about that after that. You have to think in terms of symptomatic treatment. And the key medication is, of course, immunosuppressive drugs like steroids or other like infliximab, which is an anti-TNF. And you always have to think, should I withhold or discontinue my immune checkpoint? Because what we see in the clinic is that we have patients that developed an adverse event, and we keep treating them because it's minor, grade 1, grade 2, and after a certain time, it can worsen treatment after treatment of immune checkpoint. So we have to remain vigilant, also because if you treat an immune-related adverse event, you have the risk of a secondary relapse and also the risk of a new adverse event. And also, this can happen later after starting immune checkpoint inhibitors. So this is typically how guidelines look like. I just illustrate here with the gastrointestinal guidelines. It's the same way of thinking. So signs and symptoms, assess the severity, and depending on this, either treat symptomatically or introduce steroids or either introduce infliximab. And also think about what should I do with my immune checkpoint inhibitor? Should I withhold? Should I continue it? And so these are the typical questions of the management of these patients. So yes, when should I withhold and can I resume? The question is not clear because we're early in the development of this medication. But what's for sure is that you have to permanently discontinue it for any life-threatening adverse reaction, like severe pneumonitis or nephritis. You also have to think about discontinuing it in case of your inability to reduce steroid dose, or persistent grade 3 or grade 2, or any grade 3 that recurs. At one point, and actually I would say many times when you face immune-related adverse events, you think in terms of when do I have to refer this patient to an organ specialist? Well, you have to refer when it's severe or difficult to manage. And so this can vary from one oncologist from another, but I think we shouldn't believe that we are internal medicine specialists, so we have to be careful about this. So you have to develop the multidisciplinary approach with a multidisciplinary team around you in your clinic or with the colleagues within your area, either with a dermatologist for rash problems, endocrinologist in case of autoimmune targeting the adrenal gland or thyroid, gastroenterologist whenever you have colitis, neurologist in case you have neuro symptoms, or even chest specialist in case of pneumonitis. Why should we develop such multidisciplinary approach? You have to develop it because it's important first to educate your colleagues about these autoimmune diseases that are raising up with these treatments. I think it's very important. Some specialists are not particularly interested in autoimmune diseases, but in that case, you're the prescriber and potentially you're the one who induced it in case of such autoimmune symptoms. It's also very useful because, as we said earlier, we have no idea why is the reason of these autoimmune symptoms or diseases, so it's going to help us to understand these side effects and also to improve the toxicity management. The guidelines that have been developed yet are theoretical, and I think there's going to be improvement in the coming years with the use of this new medication. Also, it's important to monitor late effects of this medication. So if you involve in the loop a specialist, he may help you to monitor in the future. So, and the last thing I was mentioning is also the fact that we are aware of these immune-related toxicities in melanoma. We start to have more experience with lung cancer, but we don't know if it's going to be the same rate, the same frequency in these types and these other tumor types that are tested right now. So in clinical practice, these are the main and the most frequent one that we see, skin. So in terms of evaluation, you have to think in terms of, to do a skin biopsy, and usually the treatment is topical treatment, and you also have to consider, depending on the severity, to withhold or discontinue the treatment. Colitis can be very severe and lead to death, especially with anti-CTLA-4. So you always have to consider colonoscopy and CT scan in case of abdominal pain. And that's where in the treatment options that have been tested pretty well, infliximab, the anti-TNF, when the steroids are not sufficient to control the autoimmune disease. For endocrine toxicity, usually it's manifested with fatigue or frilosity or abnormal blood test. Well, the typical diagnosis is based on the testing, biological testing, and the treatment is usually hormone replacement. And hepatitis is mostly discovered by abnormality on the liver function test. And so in that case, there are some report of using, after steroids failure, tacrolimus or CellCept, but still it's very experimental. For pneumonitis, I think the expertise in certain centers always lead to bronchoscopy, but depending of the patient tolerance of such exam. But that should be done at least to evaluate if it is infectious progression or autoimmune related. And same thing for the treatment, it's usually steroids, but patients are usually in a severe state, so in that case, antibiotics is added. Sometimes if they go to ICU, you have to add antifungal, so once again, it depends of the severity. And for neurological symptoms, it can be lumbar puncture or MRI. Also, steroids are used in the case of the management. So some global advice for the management of these adverse events. Usually, you have to think of starting steroids very early and to taper very slowly, because you have always the risk of potentially secondary relapse of this adverse event. So you have to monitor also very closely what's happening for the patient. Infliximab, the anti-TNF, is a good option in case of no improvement or worsening of the symptoms. So once again, it depends of the MDs that are taken care of, but in melanoma, the dermatologists usually recommend that after 48 hours, 72 hours of no improvement of a severe toxicity, you have to think of adding anti-TNF. And another key question is also using Bactrim as an antimicrobial prophylaxis. When you start steroids, there have been some reports of patients dying of infectious opportunistic infection later on after such steroids treatment. So to conclude with this, as I mentioned, these new toxicities are new and they're immune-related. And so mostly we are unfamiliar with, and maybe some of them will discover new diseases that have not been identified before. So it requires a multidisciplinary approach because it can be serious and lead to death for some patients. It requires prompt recognition and appropriate care. And also, that means that you have to educate patients and other healthcare provider about these new adverse events. And so it's interesting because it's actually bringing back internal medicine into our practice. We're not used to all these different weird autoimmune diseases. They're very rare, so I don't want you to think that these treatments are super toxic. They're not, and actually when you see your patient, you're actually surprised that they're not complaining about anything. But they can be they can be sometimes toxic for some patients, and you have to be aware and be careful with them. So think differently when you see patients. Yes, they're all not immune-related toxicities because it mostly are disease progression or fortuitous, but you always have to consider immune-related toxicity because the treatment can affect any organs and trigger very new symptoms sometimes. The last slide is just here to show you that, and we haven't mentioned combination, but these treatments are now tested in combination for different tumor types. And what we have seen is usually when you combine a targeted therapy with immune checkpoint inhibitors, it increases the toxicity. And here I'm talking about metastatic renal cell carcinoma with Sutent or pazopanib. And also, people are also testing combination of the two generation of immune checkpoint inhibitors with ipilimumab and nivolumab. And so we may have to accept a higher rate of toxicity for a better long-term response for some patients. So these management of this toxicity are very novel, but very important for the future of cancer therapy. And with that, I thank you for your attention.